Now we come to the last talk of AIOS 2025, Dr. Vinay Pillai.
Started with the first talk.
You had all the first talk also.
So Vinay
Okay.
is alpha and omega.
So
And
he
nothing in
had the
between.
first talk also 4 days back. Okay.
Last show.
Thank you, Dr. Basman and KSOS for this opportunity. So each case is a learning opportunities, and this is one case which, taught me to say never again for a case. So, 54-year-old female presented with redness in the left eye of 1 week, uncontrolled diabetic, was somewhere around 300s when she presented. Vision was 615 in right eye, best corrected. Left eye 618, right eye was normal, and this was the picture on the first day when she presented. She had a small infiltrate on the infratemporal cornea peripherally with surrounding edema, small defect, AC reaction. So the protocol in such cases is do a corneal scraping and send it for smears, grams, KOH and cultures. Started fortified cefazolin, tobramycin eye drops hourly with atropine and was sent to a physician for diabetes control. So, cultures came negative. There was no response to treatment. There was progressive worsening. Because of worsening with thinning, we did a cyanocolate glue BCL, but it kept on worsening, and this was the picture in about 10 days. Okay. Total infiltrate, coagulative necrosis, worsening. By then, her blood sugars were slowly getting under control. But then with this picture, and there is no point in waiting conservative anymore. It will just melt off, and by probably in 24 to 48 hours, you'll just have the iris presenting if we wait here. So this was the B scan on that day, practically normal. So went ahead with the graft. And now what was surprising is after the peritomy, if you notice that supratemporal area, there was extension, dense scleral extension with scleral necrosis, which forced me to do a scleral debridement there first, then marked with a large trephine, I think 12 or 12.5, but then no trephination, freehand dissection. The exudate was peeled off. Usually in such graft you get the entire lens coming out, but then it stayed. So the donor was also marked with a 12, but then not punched. Partially the scleral rim was removed along the mark, but then we needed a flange for the sclera to cover the area where the sclera was debrided. So after putting few sutures along the one margin, the other area was hand fashioned to fit the defect and sutured closed. So this was how the patient was in the post-operative period. The graft was edematous. AC had fibrin and heme, but no exudate. And the antibiotics was changed, was put on ceftazidime and vancomycin orally and systemically, along with atropine and Dorzox and other medications to control the pressures. Large graft, 12.5, you're meddling with the trab, and these patients invariably will have high IOP post-operatively. So this is how the condition progressed. There was no recurrence of infiltrate or anterior chamber exudate. So in about 2 weeks, the eye started to quieten down. We started her on topical steroids. Now, in 3 weeks post-op, when she came, inaccurate PRPL positive, but then the globe was soft, and this was the B scan. There were, choroidal detachment. So we started her, added oral steroids to the regimen. Luckily, she responded. This was how it was after, after about 4 to 6 weeks of treatment. Eye quietened, graft totally edematous, not much of view of the AC was there, even though we could faintly make out it was formed. Hypotonous globe, B scan normal, 6 millimeters. So in such situation, well, we know this extensive infection, inflammation, problems, and IOP not building. A possibility is a pre-thysical state. The eye is going into thysis. The situation was explained to the patient, and was nil visual prognosis was explained, and best left alone. After this, the patient was lost to follow-up. Okay, she didn't come back. 6 months later, there was a surprise. The patient came back, still, PL and PR was accurate. IUP was 10. The eye was doing well. The graft, of course, was failed, edematous, but then AC was formed. Okay, everything was okay. Now I was in dilemma. Okay, should we do anything or not? Luckily for me and for the patient was insistent on doing something. So we went ahead, did an optical penetrating keratoplasty with cataract removal and posterior chamber. Now, optical penetrating, we did a central ferrumber 8 or 8.5 millimeter, and this was how the patient did. And this is a scan. Anterior segment OCT showing. Not sure if it is there. Yeah, this is the old graft host junction. Sclera to sclera, and this is the new graft host junction. And we had follow-up till 2020, where the patient maintained vision of best corrected 680. So yes, cases take us by surprise. Well, should we give a good prognosis in all those cases? No, but then probably we should be a little bit more lenient there when we say nil visual prognosis. Thank you.
Thank you, Dr. Vinay. Any comments?
In all cases of corneal ulcer, we can give a thing. We need a second graft.
Sorry?
In all cases of corneal ulcer, when you do a first graft,
Post-therapeutic.
you may need a second graft.
It depends on cases. Okay, it depends on cases and how they do post-operatively. Most of them may not need, especially bacterial ulcers. Fungal is a entirely different entity altogether. In bacterial ulcers, many of them we can manage with the first graft, provided the graft is of good quality and it is not a multi-drug resistant organism, because in about 10 to 15 days we can start steroids. Okay, so many of them have clear grafts.
See, I have one question, why did you wait for so long for the ulcer to become full?
Oh.
Initially, you could have done it.
When the non-response was there, we should have done. The reason was patient.
Vinay, was the patient on atropine immediately after the surgery?
Yeah. Always. They are atropinized till 3 weeks.
Hypertrophy is actually because of the surgical cyclodylase. You have taken the sclera off.
Possible.
That area is actually cyclodylase.
Possible. But you do, the graft was only 12 millimeter.
No, but you've taken the scleral spur on one side off.
Yeah.
The necrotic thing.
Yeah, 2 to 3 millimeter.
And you can't obviously suture it back down. So you
Possible.
You'll have a scleral cyclodylase immediately. So atropine will help there.
Yeah,
That's it.
post-therapeutic, all of them are on atropine. 1. 2, in this case, initially the IOP was very high. Probably because of the fibrin and the blood, muck, everything, obstructing the axis of the aqueous.
When he was lost follow what he was doing, he was using drugs.
No, she stopped everything. Yeah.
Mostly,
Yeah.
they might have gone for second and third and
That's what I
fourth
said.
opinion.
That is what I said. We cannot, say anything here. Didn't get anything. So most likely gram negative. The way this progressed.
No, it looks like pseudomonas.
Culture, biopsy, everything. Nothing came.
They
positive.
directly played it on this thing in the theater itself.
Yeah.
Okay, so that was a good session actually. All very good cases with excellent learning points. Unfortunately, last session, but we are happy that AIOS gave one opportunity to state societies. I think for the first time, second
Yes,
time, first time. So we thank AIOS and everyone for remaining here
Yes.
till the end of that